Thank you for joining me today. In this video, I have clinical case study. This is for the 5-year-old male with chronic schizophrenia. And he has stable house, reliable clinic attendance, history of responding well to antipsychotic medication. But currently issue is he stopped the antipsychotic medication because you forget that. Clinical presentation for this patient is he has a positive symptoms, controllable previously, now relapse. He has a paranoia with hallucination, physical exam, smile-based rigid. So he forget to take his antipsychotic medication and he's presenting to the clinic with positive symptoms of schizophrenia. Schizophrenia has, if you watch my other videos, schizophrenia has a positive and negative symptoms. He has a positive symptoms today, and they are controlled previously when he was taking his psychiatric medication, but now he relapsed and he has a paranoia with hallucination. Physical examination, he has baseline rigidity. So clinical decision is to make a long-acting injection. What are the options? The options are Fluphenazine, Haloperidol. Those are atypical long-acting injections. The reason is he need strong D2 blocker. D2 blockage is because he has a schizophrenia and he has a positive symptoms of schizophrenia. That means he has a lot of dopamine. And these medications, they lower the dopamine by blocking the dopamine in D2 receptors, and that will reduce his positive symptoms of schizophrenia. It will lower the paranoia and hallucination symptoms. It already shown more vulnerability of rigid because he already had rigidity. Fluphenazine is a high potent. It's high potent medication and excellent symptom control. Fluphenazine. However, it has eflaxar. That is the other name of it. So eflaxar has higher potency and excellent symptom control. It can control the positive symptoms, but it also has high risk for EBS burden among long-acting injectionists. So Effexor has a high risk of causing muscle rigidity, abnormal muscle movement that called EBS. It will worsen for someone who already had a rigidity, and this patient has a rigidity, so it's not the best option. We have a Haldol besides that, but Haldol still has high EBS risk, and it also has QT prolongation, so it can cause muscle rigidity, it can cause heart failure or a stroke or arrhythmia for patients with heart issues. So the best choice is to use atypical long-acting injections like risperidone, like the risperidone, aripiprazole. You want to teach the patient, if the patient is still stiff, do not give them this drug that make them stiff more. You want to monitor EBS. You want to assess the AMS scale baseline, and that should be ongoing. So you want to assist them again and assist them again. Also, it causes weight gain. It causes weight gain, and it causes Invega. This is the Invega. So Invega, even though it is better than Haldol or Effexor, it can cause weight gain, and it can cause prolactin risk. So it will increase the, also it has ABS and prolactin and weight gain, so it has all these three severe risks. You want to educate the patient. This medication lowers the risk of movement side effects compared to other injections. However, it has a positive weight gain and hormonal changes like prolactin. I also have another case study, and this is agitation relapse. This patient is other patient, and this patient is called Mr. R. He is 28 years old male. He has acute psychosis with agitation brought in after aggressive episode. He has a history of responding rapidly to Haldol. Now he has severe hallucination, disorganized behavior, non-adhesiveness. He's not taking his medication, and he has those positive symptoms. So you want to control the symptoms with long-term stabilization. You need a rapid, potent, and psychiatric effect medication because this patient is high risk of a harm. You want to prioritize control first. That's why you want to use Haldol. So the best option is Haldol because Haldol has a strongest dopamine blocker and effective for agitation. You want to give the patient a monthly dose, long-acting injection, and long clinical experience. A typical long-acting injection's first line is slower. So if you give the patient a typical antipsychotic, it will take longer, but typical active faster. There is a typical and atypical. Atypical is slow, typical faster. So typical blocks the dopamine quicker, atypical blocks the dopamine slower. And on atypical long-acting injections act slowly in some cases and less effective for extreme agitation. You want to use first the oral and then you want to bridge that to Haldol long-acting injection. First, you want to give the patient oral Haldol. You want to see how the patient acts. You want to see if this is good fit for this patient, if it's controlling the symptoms, if it's not causing EPS symptoms or muscle movement side effects. Then you want to switch to and bridge that to long-acting injection. You want to control the behavior and you want to see if the patient is tolerant. So the reason you want to give the oral, you want to see that how this patient is controlling the symptoms, how the patient can tolerate this medication. What are the side effects of Haldol? The side effects include EBS, akathisia, and dystonia. Also QT prolongation. So you want to have a baseline EKG. And you want to assess neuroleptic malignancy risk. For follow-up for the long-acting injection is every 2 months, control psychosis, compliant. You wanted them to feel. He's complaining about, I feel restless, I can't sit down. That means he's agitated. Haldol is classic for akathisia. So Haldol causes akathisia. That is the classic for Haldol. You want to manage by adding to Baradol. Consider switching aripiprazole. If you're near to, you can switch to that. If the Haldol is not working for the patient, you can switch to Abilify. You want to educate the patient. This medication works faster but might cause stiffness or restlessness. We will monitor closely. That's how you're going to educate the patient. Haldol is a hallmark. Use it when symptoms are loud and dangerous, but do not forget the cost. Second case study that I have for you is Abilify and Invega. This patient is 38 years old male. He has schizophrenia. He's obese. He has a diabetic and he's pre-diabetic. He is not taking his medication orally, so you wanted to switch to him Abilify and Invega. Why use Invega and Abilify? Because he need long-acting injection, but you don't want to cause metabolic risks. Clinical decision making is atypical. You want to choose atypical long-acting injection, Invega, risperidone, Abilify. Those are the medication you would like to choose. However, risperidone and Invega, they increase hormone such as prolactin, and they increase the weight. Abilify is a partial D2 agonist, so it blocks dopamine partially. It don't block all the way. That means it causes less EBS. Lowest metabolic risk. Also, it has the lowest metabolic risk. That's what you wanted. You wanted them to have less metabolic risk. He's already diabetic. He's already overweight. You don't want to increase that, so you want to have less of that. You want to give medication that has minimum side effect of prolactin effect, and you want to have medication that has lower metabolic risk. You want to prescribe medication that has less EBS. So that is Abilify. And the reason being is this patient will die from diabetic before psychosis. Before you treat the psychosis, this could lead to diabetic if we ignore the metabolic risk. That is the reason that you want to prescribe Abilify. So Abilify has metabolic advantage. Abilify is high risk for akathisia risk, muscle movement risk, and slightly less sedative. You want to monitor the weight. You want to monitor A1C. You want to monitor the lip liver panel. You want to monitor akathisia, and that is the abnormal muscle movement, because Abilify is high risk for akathisia. When you remember Abilify, remember akathisia. Abilify, akathisia. So Abilify causes akathisia, which is severe risk of muscle movement and rigidity. You want to educate the patient. This option is lethal for your body weight and blood sugar, but it has restlessness and trouble sitting still. So if they feel restlessness and trouble sitting still, they should report that. You want to follow up report. You want to follow up basing or akathisia. You want to add to Abilify propranolol, low dose, or switch it if it's intolerable. Some patients cannot take Abilify. So if they cannot take Abilify, you want to give them propranolol. It's blood pressure medication, but it also has the effect of psychiatric effects. So you want to add it to that or switch to that. Even though it's a propranolol is a beta blocker that has a psychiatric features of label, rather than its mood stabilizer. It blocks adrenaline channel, so it's good for anxiety and PTSD. Okay, so if the patient has a EBS, you want to give them a typical long-acting injection that will lower the movement side effects and improve metabolic risk. It has a metabolic risk, yes. Acute agitation, you want to use Haldol. Haldol has a strong dopamine blocker, but it also has EBS and QT prolongation. If the patient have metabolic risks like diabetic, high lipids, overweight, you want to prescribe Abilify. Abilify is the least metabolic risk, but it has akathisia effect. So Haldol is the best for a severe agitation, but watch QT prolongation and EBS symptoms, side effects. Invega is best for convenient but has a prolactin and metabolic risks. Abilify is the safest metabolic but causes akathisia. Thank you for joining me today. I will love to see you in my next video. Thank you.